Hey, and on This Week in Pharmacy, coming to you live. It's Friday. I'm glad it's Friday, March, what is this, 6th? March 6th. I want to welcome a friend of mine, somebody that is a fellow marketer, fellow person in communications, has been a member of the Pharmacy Podcast Network for some time now. I can't remember exactly how long, but Austin Murray, welcome to TWIRx.
Absolutely, Todd. Thanks so much for having me on. Always a pleasure to sit down and talk with you. Even outside of the podcast, we have a lot of conversations, so it's always good to see you.
Absolutely. And today you're in Orlando right now, down at the Atrium X conference.
Yep. So I am in Orlando this week for the Atrium X conference. That's the conference by Dr. Nicolette Mathy and Atrium 24, Dottie, that whole platform. And this is the second year they're doing this. Really exciting. Last year I went. I loved the format. Loved how they come up with topics. They let the pharmacy owners come up with the topics on the spot that they want to talk about. And so this year I'm excited to see what the challenges are that they're dealing with.
I was so excited to go to the inaugural one that Nicolette put on. It was one of the most interesting pharmacy conferences I've ever been to. It's still not to the level like that I get the vibe from HLTH Health or I get from Vive, that they're taking other things to the next level. They're using dynamic LCD boards everywhere. They're interacting on social media live where you can see people talking about, issues that you're like tracking. And so I think that pharmacy conferences are almost there, but Nicolette is a pioneer in that because she's stretching the standard conference and she's kind of taking it to a next level. So I'm very upset I'm missing the second Atrium X because my daughter got the lead in Matilda and she's in the senior class play and she's only in 8th grade. So I had to be in Pittsburgh for that.
Oh, well, you can't miss that. You gotta go to that. So absolutely understandable that you're going to that over Atrium X. One thing I will say to kind of touch on what you said about Atrium X a little bit, I like to compare it almost to like a mastermind. So it's really cool because it's less about hey, let's go to this session to get this CE and talk about or learn about this topic, and more about it's more interactive and more about what is how can I take my pharmacy truly and ask people that are also doing it really well to the next level. So it really is like that mastermind experience, but a little bit on a larger scale.
Yep. And shout out to Bruce Nealon for being a Pharmacy Podcast Network member for quite some time. His insights through Pharmacy Crossroads is just incredible. He is going to that event being powered by Dispense Times. Shout out to Josh Parastani, one of our Pharmacy 50 most influential people. And Josh is such a behind the scenes. He's a pharmacy marketing ninja. And he always wants to stay behind the scenes and pull levers. And I love what he does. So he's going to power up Pharmacy Crossroads. And then Bruce is really going to dive into what's happening, how it's impacting community pharmacy. And I love being part of that. You know what my dream is? I've already told you about this, Austin. So listeners, you're more than welcome to act on this. But we think of how many conferences are happening per year that pharmacists should have representation at in some capacity or something. I attend between 8 and 12 conferences per year, and that's really too many. It's very stressful on our family. It's disruptive, but nonetheless, I really want to be there. I think it's important. I want to take what Dr. Adam Robinson has done. He's our coverage for the Cardinal Health RBC. And I want to give a shout out to our network as well as to the rest of our listeners that we should be covering more conferences and we should have pharmacists talking with other people and pharmacists and people that aren't even pharmacists, technicians, for goodness sakes. So I do want to grow the coverage of what we're bringing so that people that are tuned in through podcasting can say, holy crap, I should have been involved, or maybe I can take action, or maybe I can partner with somebody. But that's the importance of all this is it's to bring the best of the best together. So I'm so glad that you're going, because you always have a good post-conference perspective to really bring some highlights. So talk to us about what Sykes is going to be doing there and what you're hoping to achieve.
Well, we're obviously we've got our booth that we'll have there. I think one of the things that is my goal, and this isn't just strictly for Atrium X, but for every conference, is what are those kind of maybe obvious but also not so obvious challenges that pharmacies are facing. It's easy to look at an agenda like RBC or ThoughtSpot and kind of see like, okay, they have all these CE sessions planned out. We know in general what the challenges are: reimbursements, cash flow, things like that. But what's I love about Atrium X is it kind of approaches they kind of look at challenges that maybe aren't covered at some of these major conferences. And those are the kind of conversations that I love to have, because that's when you can really start to dig deep into what pharmacy owners are also facing, outside of the traditional challenges that they're facing as well. So that's kind of the most exciting part. What I'm looking forward to the most about Atrium X and what we're going to be doing there is going to a lot of these playing these on the site sessions that they're going to be hosting. So that'll be exciting.
Hey, I want to shift gears, and I want to share with the listeners, if you're watching us live streaming on LinkedIn or YouTube, that's great. You'll be able to show you what we're about to show you and discuss some marketing. Going to shift the gears to marketing, and a shout out to the National Community Pharmacist Association, the NCPA. We absolutely think that this campaign that Austin and you and I we've already kind of talked about this, but I want to share this with our listeners. This is a national campaign. This is a national message that's going to be pushed out to the public about pharmacy. Let's take a listen.
What do you love about mail order pharmacies?
I love it when my hemorrhoid medication gets mistakenly delivered to my neighbor.
I love not being able to talk to a human when I have a question.
Please remain on the line. I love it when my prescription is delayed or doesn't show up at all.
At your locally owned independent pharmacy, you get the personalized, friendly service you deserve. Visit your locally owned independent pharmacy today.
All right, so technical difficulty there, but nonetheless, excited. And listen, I've been around in pharmacy since 2004, Austin, and I've always wondered, why in the world isn't the APHA and the state pharmacy associations and the NCPA, and for goodness sakes, let's just take money from every single association in the entire country to do specific campaigns to educate our public about what the truth is about how pharmacy care impacts your life, number one. Number two, how best to get access to that care based on the fact that you're probably not digging into some of the best pharmacists that you can have in your community, which is going to come from independent pharmacy versus, I mean, I love chain. I don't want to see chain shut down. When Rite Aid shut down, it was horrible, the impact that it had on the nation. The closings of pharmacies is having a huge impact. But the cream of the crop of stories that I've heard from people being cared about has come from independent community pharmacies.
Yeah, absolutely. And I think that there's a big opportunity right now. There's a lot of frustration around chains, and your CVS, Walgreens, a lot of frustration around wait times and the level of care that you get. And this is something that independent pharmacies have always thrived at, outperforming these chains is level of service, areas of care that they can get into that CVS and Walgreens either can't get into or won't get into, right? I mean, I've heard you talked about this, and we've talked about this at Sykes a lot, is long-term care at home, clinical services, all these other areas of care that the big chains can't get into. And, you know, one of the things that I think is a big opportunity right now, the NCPA has this national campaign that they're rolling out.
Yep.
And the positioning and the messaging that they're sending across is fantastic, which is, are you sure that as a consumer, you actually enjoy these things? And I love that because I think pharmacies right now, I know one of the benefits with this campaign is that you can kind of get targeted custom ads based on your pharmacy. I think this is a great opportunity to kind of double down on that increased exposure where, within a 3-mile radius, you've got this ad coming out. You can market your pharmacy within a 3-mile radius and tap into that increased exposure that you're already getting from this campaign, kind of market some of those other additional services because, NCPA is casting a broader net here, which is fantastic. And so as a pharmacy, you can kind of lean into that and, showcase that you have clinical services, showcase that you have long-term care at home, things like that, that are these areas of care that, consumers maybe they don't know that that they had available at an independent.
Yeah, in the show notes, you will see the link to the press release that came out this week in pharmacy, and that was the NCPA launches multi-million-dollar national ad campaign to promote independent pharmacies. Let me just make a comment about this real quick. The timing, I'm not sure if it was purposeful. If it is, then they're freaking geniuses. And I think maybe they should take credit. But the timing of releasing this campaign, Austin, with the heat and the fire and the exposure that we're finally putting on in PBMs and educating the public of what the hell a PBM is, what it does well, what it does horrible. All of a sudden, Mark Cuban's in front of Senate, and the Senate, Josh Harley, Hartley's going, Harley. What's his name? Josh?
I think it's Hartley.
Yeah. I mean, he's starting to take, the teeth and Buddy Carter and like, oh my goodness, like Jake Auchincloss, like they're getting their face completely, like it's going to be a whole, like they're getting the crap beat out of them. So now we have this campaign that it's funny to watch, it's humorous, it's educational, and it's bringing attention that you're going to have someone watch this campaign and they're going to be like, why do I go to CVS and stand in, these long freaking lines? Yeah. I feel like I'm at a fast food. Wait, why would I treat my health like fast food? I should go to the homegrown cooked pharmacy care services that's in my hometown, knowing that when I'm supporting them, I'm supporting the community's jobs and there's more of an impact and there's a story to this. So the timing of this, what do you think? You think it's freaking on, the planets aligning?
I think it's good timing. I don't know if it's necessarily planned or I know that NCPA was, when we had Doug on our podcast, he's come on our podcast several times, but I know this was something that had kind of been talked about for a little bit, and they announced it at the NCPA show that they were launching this branding campaign. A lot of that was with I think the excess funding that they had from the original big PBM push that they had. What I will say about the timing is there's a big shift, especially with the younger market. I know people in my age bracket that there's a big shift towards preventative health and towards holistic health. You mentioned earlier about pharmacies and kind of their more exposure of them at trade shows. One this past year was A4M, which is a trade show that's all about holistic health. It's about that all around wellness. And when we had Nicolette on our show, she talked about how she saw several of her pharmacy clients that had booths at these trade shows. So a lot of the national GLP compounders, a lot of the national weight loss compounders that she works with were at this show. And what I think that indicates one, an opportunity for pharmacies, local pharmacies, to get more into that holistic health, um, where you've got these younger people that are prioritizing more of their health. They're prioritizing more of that preventative care. And as a pharmacy, you can kind of lean into that a little bit more. And I think it also shows just, like I mentioned, where the market is kind of shifting. So I think this is a great opportunity and great timing for this campaign to kind of come out to showcase people like not only are you standing in line at CVS for this prescription, but they're also not prioritizing your health the way that an independent would, and really getting you back to a more functional and better state of health that you're in, which actually helps lower overall healthcare costs.
True. And I want to defend our CVS pharmacists that might be listening right now, or CVS technicians. You're forced to act, and you are forced to operate the way the metrics are set up in the CVS health system and pharmacy output system. So it's not like the pharmacy tech or the pharmacist on staff, especially the pharmacists that are in charge. They have so much stress on them to perform. I mean, Dr. Katie Forbes, she's one of our Pharmacy 50 most influential people, I think 2 years in a row. And she's now been featured on another big podcast. I can't remember the name of it, but it's huge. It's a consumer podcast. And she's saying, listen, like, it's not the CVS pharmacist team's fault that there's so much pressure put on them to perform strictly for output and profit. They don't give a shit. The policy within CVS Health's ecosystem, those upper people who have a legal responsibility to their board and to the shareholders to perform in a most profitable way possible. They don't give a shit about the grandmother who has a rash that through mail order, nobody's looking at her rash. It's getting worse. It's getting red. She shows up at the pharmacy to pick up her whatever medication. And now the pharmacist looking at her says, whoa, like, what is this rash that you have? Let's take a look at this. Let's slow down for a second. Let's put some, something on that, and then let's get a prescription for whatever that is to help you. Like, nobody's doing that at CVS.
Well, and I agree with you, Todd. I don't know what kind of TV you watch, but I've been really fascinated with The Pit, which is it's an HBO series, and this isn't a pharmacy exclusive challenge. This is an all healthcare system challenge where there's all these different performance metrics that people have to hit, and it comes, you come into an environment where you really want to focus on patient care and focus on, like I said, elevating that patient experience, but you're forced to perform a certain way, and you're forced to perform for that profitability, which leads into, some of the opportunities in terms of messaging around what's next for PBM reform. I think for independents right now, one big opportunity is shifting the message to, here are the gaps in care that we can help fill that maybe are not being taken care of at like a larger chain. And because a lot of these rural areas, the independent pharmacy is all that they have. They might have an urgent care, or they might have a smaller hospital system, but the pharmacist is one of the most trusted providers in the area. And so I think there's a big opportunity now to kind of change the narrative of, okay, we've got this PBM reform that's passed. Here are other things that independents do as well that, these areas of care that we could help fill. And I think you get a lot of congressional leaders to listen to that message and tune into it.
On HBO Max, there's a program, not sure.
Pharmacist. And if you've been watching The Pit, you know that a clear character on The Pit has been missing, which is an ED pharmacist. And word on the street is that they did have a pharmacist on this episode this week. So let's watch, and I do have some thoughts about it. I want to start off this video by saying, first, I'm overjoyed to see a pharmacist character on The Pit. If you know me in real life or follow me here, you know that I've been advocating for a pharmacist on the pit forever. And I even got to attend a season 2 screening with Figs, and I was able to print out this article that a lot of ED pharmacists put together, and I thought it was so well written. It's called The Missing Piece in the Pit, a call for emergency pharmacist representation. I printed it, brought it, put my email, phone number, contact information, where I work, and talk to the HBO Max team. Offer them even to help in any way, allow them to shadow me for a shift. That way they could see what a real day-to-day of an ED pharmacist would be like. So I'm glad to see that there is a pharmacist character this season, and let's now get into my thoughts.
Medications are locked up in the PDS.
The PDS is getting unlocked by a clinical pharmacist, Dr. Megan Nord.
We've got your back.
First thing I noticed is that they introduced the pharmacist as a clinical pharmacist, which I think is also a huge controversial topic in itself, because I do think that any pharmacist is a clinical pharmacist. We all went through a doctor of pharmacy program to get this degree. So I think I wish they would have
I'm
referred.
excited about that. Big news for clinical, she says clinical pharmacists, but pharmacists in general. It's going to get more exposure. The team, there's going to be a child out there. It's going to be in 8th grade. They're going to love science. They're into STEM. They're into technology, but they don't want blood. They don't like, they want to be a doctor without the blood. And sure enough, a pharmacist is finally going to be represented, that these people are out here doing some badass things.
Well, I want to touch on something that she mentioned in the video that kind of want to emphasize a little bit more about how, the character gets introduced as a clinical pharmacist. And what's controversial about that is that all pharmacists are clinical. This is something that we see with, pharmacies that we're talking to, is a lot of pharmacists want to practice at the top of their license. So they can already do those things that gets introduced in the show. The hurdle there is how can they get more into that, and how can they service their community a little bit more.
Yep.
So I thought it was really interesting that she brought that up, because that's a trend that we see.
That's a shout out to Dr. Leslie, who you can follow her on Instagram. It's at Leslie Farm D. I follow her on Instagram. She's got a really big following. I would consider her a social media influencer for sure. And we need more of those. I think Pharmacy 50, I think there were 6 pharmacists that were social media influencers that came from like the TikTok and the Instagram world. And it goes to show you that everything is changing. We're seeing PBM reform taking place. We're seeing the NCPA finally put out really well done commercials to the public. We're seeing the APHA do some things. We're seeing our State of Pharmacists Association starting to do patient driven. And I'm like, wow, like this is all happening at the right time to truly build the profession of pharmacy the way that it needs to get paid. It needs to have pharmacist representation. But then I want pharmacists spilling out into other things that aren't necessarily directly pharmacy, but definitely healthcare.
Yeah, absolutely. And I think that's what's next, Todd. I think the way that things are shifting, it's shifting more towards that clinical per se model where, pharmacists are going to have more opportunities now to practice at the top of their license. I know many states have started to recognize pharmacists as providers. And so that helps fill that healthcare need and that access to healthcare in these communities. So I think that's where things are kind of going next. And so it's exciting to see.
Hey, today's episode of This Week in Pharmacy is sponsored by Sykes and Company. We are very appreciative of the support that Sykes has given to the Pharmacy Podcast Network, the expertise of Scotty and the podcast team, the Bottom Line Pharmacy Podcast, Master the Margin Podcast. Talk to us about your podcast content. What's happening coming up in the rest of 2026?
Sure. So we've got a couple of great episodes. This releases on Friday. So, this week we had on an infusion consultant. So what she does is she consults different infusion pharmacies, whether you're a startup or you're a little bit more established. She helps with their business operations, staffing, things like that. We've also got an episode coming up next week with the NCPA. We had Dr. Hashim Zabak and Mark from the NCPA on our show to talk a little bit more about what what the NCPA is, how it got started, the history, kind of the stuff that they do. We really get into the nuts and bolts there. In terms of what's coming up with the podcast, we've got a lot of great guests coming up. We've got some on AI compliance, which has been a really hot topic in terms of, how can I integrate artificial intelligence into my pharmacy, but also stay compliant. We've got a couple different shows. Obviously, we've got our flagship podcast, the Bottom Line Pharmacy Podcast, and then we've got the Pharmacy Ownership Podcast, which talks a little bit more about buying, starting, selling pharmacies. And we've got some content with Master the Margin as well, which is a little bit more of the granular accounting side of things. We talk about 340B accounting, the balance sheet, things to look for, stuff like that. So really exciting stuff on the podcast side of things and on the content side.
All right. So please go tell Nicolette and the team that I said have an amazing show. I'm sure it's going to be. I can't wait to hear from Bruce. I can't wait to hear from you. Would love to have you maybe even come back and tell us how things went. But excited to have you on TWIRx today. Thank you once again for so much of your support, and have a good time in Orlando. Get some sun, get some of that vitamin D.
I'll try to. If I'm not stuck inside the four walls of the hotel, if I can actually get out of the door, I will. I'll get some sun. So absolutely.
Right. Thank you. Thanks for being on
Thanks,
TWIRx.
Todd. Yep. Thank you. Thanks for
Feeling lost with the complexities of pharmacy accounting?
In pharmacy today, there's so many different, variables and issues that impact the pharmacy books, records, accounting, the profitability of the store, so forth. There's different components of pharmacy that have its own nuances from an accounting standpoint. And so it's tricky. There's no doubt about it.
Ready to take your pharmacy to the next level but don't know where to start? Sykes & Company is here to help. Introducing the RX Assessment. With the RX Assessment, the pharmacy CPAs and advisors at Sykes will do a deep dive into your accounting and tax situation and give you the action steps you need to take your pharmacy to the next level.
If you're interested in, working with a team who understands the industry and how the accounting and tax should really be in a pharmacy, this is your chance to get a under the hood check of what's going on and getting the feedback of any issues or concerns or, again, things we think you're doing really well with.
Get the financial checkup your pharmacy needs and head over to sykes-cpa.com or call 252-482-7644.
Hey there, hey there, hey there, hey there. Now on This Week in Pharmacy, I'd like to welcome one of the Pharmacy 50's most influential people in pharmacy, and this has become an international awards program and reach. But I'm so excited to have Mark Duman on the show on TWIRx. Mark, it's so good to see you.
It's great to be here. Thank you very much, and thank you for accepting people with strange Scottish accents.
No, you in American culture, that's actually cool, because we immediately think of how Hollywood has propped up any person speaking with a British or a Scottish or some accent. You always seem to be more intelligent, so you have that to your advantage.
Well, you did say American culture, which we joke is oxymoronic, but that's another story. Let's not go there.
That's another podcast for us.
Yeah.
Well, to start out, Mark, I want to say congratulations that you were recognized on a global level. So when I started the awards program, I didn't even get 100 votes that first year. I think we got like 85 or something. And it was kind of embarrassing for me because I'm like, maybe this isn't going to go anywhere. But last year we had about 3,000 votes in participation, and now this year we had over 6,400. So it doubled our international reach. We had I think we had 4 people that were international superstars in pharmacy. So that's just saying something, that pharmacy is changing, the pharmacist role is changing. And when I started to creep on you and stalk your profile, I realized that I understand, based on your background, why you made this list. But you're very humble. So just share with our listeners, a little bit about yourself.
Yeah, well, I'm surprised I made a pharmacy list, because I came off the pharmaceutical register a good few, it could be even 8 years ago, and they did try to get me back on for COVID, and I said no, it's probably more dangerous, and I don't think you have a training budget large enough to make me safe in a dispensary and talking to patients directly. So I do feel humbled to be on a list and to be internationally recognized. I'm not quite sure why, but it may be to do with the fact that I sort of have taken pharmacy at a very different level and a different approach. And I think I'm very much about putting patients and people before medicines. And that really has been my career. I remember sitting in Aberdeen in 1990, before maybe you and many listeners were born. And it was the prize giving in Robert Gordon's. There's only 2 schools of pharmacy in Scotland, one in Aberdeen and one in Glasgow. And being a Glasgow boy, wonderful parents, but wanted the full university experience. I wanted to go away from home. So went up to Aberdeen, which is a 3-4 hour train journey. So it was pretty far away, like in the true north of Scotland, where everybody wears kilts and tartan, or plaid, as you would say. And anyway, I was sitting in the prize giving in 4th year, because at that time, England was a 3-year degree. We were a 4-year degree, always have been. And someone said, the pharmacy practice prize has gone to Mark Duman. And I was sitting in a drunken stupor or a hangover or both, and said, wow, Mark Duman's won the prize. And they were like, you're Mark Duman. I said, oh, yeah, right. And I didn't know then. Why am I telling that wee anecdote? Because that really was the sort of golden theme that has run through my career. And by all means, please look me up on LinkedIn. I won't bore the audience with that whole journey. It would take 20 minutes. But suffice to say, I did the pharmacy thing. I enjoyed the pharmacy thing. I get ridiculed by my dispensary support staff for wanting to talk to patients about medicines taking and not just know their address. And really was into trying to make people embrace not so much their disease, but the way to live with their disease and with their conditions, as opposed to be a deficit and not to be able to be an asset. And that's what's followed my career. So I went to a think tank called the King's Fund and worked a lot on shared decision making. In 97, set up the Patient Information Forum. Prior to that, I'd actually worked with Cerner, your big electronic health record system, which I believe has 26 sites now in the UK. Trying to anglicize a multi-American database was quite funny. It went way beyond spelling estrogen with an O, and finding that acetaminophen was not the same as paracetamol. And then I went to the BBC and did a bunch of stuff there around behavioral change. I went into telecoms. I went into traditional Chinese medicine, which really rocked my RCT is the gold standard of evidence approach. And I think for me, the big lesson in all of this, Todd, is to realize and recognize one's own subjectivity. We see the world as we are, not as it is. And you need to listen twice as much as you speak. And that makes you a better clinician. It makes you a better parent. It makes you a better spouse, and it makes you a better person. And I think too often we listen with the intention to answer. And having brought up and still trying to bring up 5 kids, the 3 older ones will tell you, Dad, listen, never. And now I don't speak. So I don't think I parent anymore, but the 2 younger ones seem to be delighted with that. So I think it's a really important trait, which is if we listen to people and we let them in, we will be better clinicians. And I think that's where pharmacy can really step out on its own. We are, in this country at least, readily accessible. We don't need to book appointments. We have counseling rooms. Get out from behind the dispensary and talk to people, make a difference, talk to people, don't talk to medicines.
I love that. And that kind of folds us into what I wanted to tell our listeners about. You have an entire initiative behind the scenes that plugs into a lot of the things that you do, which is the attitude of illuminating what the patient is going through and what they feel in healthcare from their perspective. So if you're watching us live on YouTube, or you're watching us on LinkedIn, you'll see on your screen, if you go to illuminate -pe and .com, it's the website that kind of describes what is this Illuminate. But share this with our listeners.
Yes, thank you, Todd. This is one aspect of what we do. We developed this about 10 years ago and have used it with about 10 different organizations, pharmaceutical companies, some provider organizations, some med tech companies, the Royal College of Surgeons. We did some work with them on it. And it's about everybody talks about putting the patient at the center, but do we really walk it? And what this does is has 7 domains, 86 indicators, and helps mainly now pharmaceutical company, life science companies to not just look at corporate reputation and look at their advocacy work, important as that is, but this looks across the entire piece and says, where are you performing through internal interviews and surveys, some deep dives into brands if appropriate? Where do you really walk the talk of putting the patient at the center? And where do you need to walk a little bit quicker, a little bit faster, or even walk at all? It covers a whole asset life cycle from R&D right the way through to disease awareness campaigns and patient support programs, through commercial. And we've worked with some of the big companies that are on the website, and it's whether it's Illuminate or any other tool, I'm not really bothered, but just measure what you do, measure the impact. And I think one of the things we need to be asking our patients is not just, do you take your medicine, but how can I support you to be more engaged in your own healthcare? How can you do more self-care and more self-management? And I, 15 years ago, contracted, in inverted commas, inherited, thanks, Dad, but also my own lifestyle, type 2 diabetes. I remember when my GP, my general practitioner, my family physician, as you say over there, said to me, Mark, you've got diabetes, you're too fat. And I was like, but doctor, you're fat too, and you don't have diabetes, And he was like, well, I'm not genetically predisposed. I said, well, don't be so quick to judge, So even within that delivery of a diagnosis, there's stigma. And he's a lovely doctor, but again, it's back to we see the world as we are, not as it is. And I think you still, call it retail pharmacy. We call it community. And I think that says a lot beyond just a word. Retail pharmacy shouldn't just be about the money, important as we get paid and recognized for what we do, but it's about a sense of community. Can I go to my pharmacist and ask about my medicines? Can I ask about my condition? Can I ask about prevention? What is social prescribing? What are the social determinants of health? How can I do more supported by my medicines and supported by my pharmacy?
It's interesting you pointing that out, because we don't say independently owned retail pharmacy. We say independently owned community pharmacy. But then if you go over to the more corporate driven, they're the ones that say retail pharmacy. And it shows a contrast between big chain pharmacy and the privately owned organizations. And even though there's wonderful pharmacists that work in the chains that mean well, there's a lot of times that they're held hostage to metrics and to getting volume out instead of quality healthcare, to slow down for a second and freaking listen to what the patient has to say and be more empathetic and more understanding about what they're going through. And those big corporate chains, they're not set up, that mail order environment that is just shipping, lick the label, slap it on the package and get it out the door so that we can charge more money. That's not what healthcare is.
Yeah, and it's definitely not what I don't think pharmacy should be. But again, we need to be paid for that recognition of going beyond licking, picking, and sticking. And I don't know if some of us want to or some of us don't want to. And I think some companies do, some companies don't. And the issue is often that we will try to claim some turf. I mean, in the UK or in England specifically, we're now taking on 7 minor ailments, which is relieving, again, the primary care burden, or at least passing it to community pharmacy. And we can do these things. But I think what might change, Todd, and I'm not sure over that side of the Atlantic how quickly, but we talk an awful lot about value-based healthcare and value-based outcomes. Yeah. And this is going to upset many of my colleagues, but I'm a little bit embarrassed to be part of a profession which is in most cases the last person to see the medicines taker, or in 50% of cases the medicines taker not, i.e., 50% of patients aren't taking medicines as prescribed, and I'm the last person they've seen. I get paid anyway Pharmaceutical companies get paid anyway. If we truly want value-based healthcare, we need to close. And I don't even like the word adherence because it passes the buck to the kit to the patient. Oh, it's your fault. You've been non-adherent, you naughty child. We need to take responsibility as a profession for that. The industry needs to take responsibility. The payers, providers, and policymakers need to close the gap and really start looking at adherence. And I would like to see an industry, and this is, let's hope Trump doesn't hear this, but I'd like to see an industry that is paid when the outcomes that were submitted in the trial match those real world evidence data that's coming off of the wearables and the patient records that we all have.
That's wild. That's a great idea, because you have the ability to capture data through wearables, through some of the things that are coming from documentation. We have pharmacists who are becoming much more holistic in spreading and in combining the pharmacological with, nature and food as medicine. But yeah, I think the outcomes target, maybe it's not the full payment, but maybe it's like either a bonus or it's like the rest of the payment, like some of the payment you're holding hostage. But if you could have that closed loop circle in place where pharma wasn't getting the money up front, but they're getting a partial part of the money until it comes full circle, where the clinician, the physician, the pharmacist, and all of a sudden we have 30 days of data or 90 days of data or 12 months of data where we're showing positive outcomes happening in this patient's life. And that would encourage communications, and it would encourage patient engagement, like Illuminate spells out, with insights and owning it, owning the what this does, and then of course the impact, and then that encourages innovation, because as well as I do, Mark, that there's a lot of parts of the jigsaw puzzle of healthcare that haven't changed in 30 years because they don't want to change, and that's not conducive to better healthcare.
Yeah, we really need to, I think, take the medicines taking topic, adherence, persistence, compliance, whatever term we want to call it, and really move beyond publishing papers and doing pilot stuff. There's a global group called ESPACOMP, I think maybe 400 or 500 people. They're beginning, I believe, to bring patients into the work that they do. But I don't know what their currency is. Is their currency publications? Is their currency solutions? Is it the adoption of these solutions, et cetera, et cetera? And I think we really need to begin to look at the medicines taking or medicines experience. And, I take medicines. I have 7 or 8 pens sitting in my fridge at the moment, all of which have the last dose in them. The medicine itself is better than the previous medicine I was on, but the delivery system stinks. So when we develop medicines and we develop, cell and gene therapies, and we're asking parents and patients to use much more complicated devices, could we please develop these with them? I think that's absolutely key. There was a Italian foundation, I believe, a couple of months ago that has just won either EMA, I think it's EMA approval for a medicine that was developed by parents. So we're beginning to see patients. Yeah, it's different. We don't only have to wait for pharmaceutical companies to develop medicines and biotech companies. Parents, driven by that desire to cure and to alleviate pain, can get involved too. So stop seeing us as passive recipients and bring us in as active participants. And even the old blister pack, and again, I think it's different in the States in terms of dispensing, but everything here in the UK is blister packs. And the medicine that I take every morning and every night to keep me going, I'll cut my fingers once every 3 months. So I get a neutral, if not negative, experience of what is a very beneficial product, because we don't think about the wraparound medicines experience. We think about the economies of scale and pharmaceutical production lines over the patient experience. So I think we need to think a little bit differently. And I really call on pharmacy and pharmacists to begin to put the patient and the person before the product. I think we're in a great place where we're accessible, we can communicate, we know about medicines. And if you don't have the confidence in terms of communications or in terms of health coaching or in terms of behavior change, go do a course. speak to your public health colleagues. Let's get out there from behind the dispensary and from behind the counters, and I'm sure many are doing it. And let's really build that community spirit and bring, that role of pharmacy into being a key player in improving outcomes in healthcare. I think I'm going to stand for election now. That sounded great.
Yeah. And let's talk about that for a second, because have you ever been part of the Royal College of Pharmacy, or one of because we have the APHA in the States, where it's like leadership is changing. We're seeing a lot more usage of digital health, and we're seeing a lot more patient involvement, and we're starting to also see that it's not just about the association, it's more about kind of supporting the pharmacist. But what kind of insights
don't get me started. Yeah, I've tried a couple of times. I've given up. I think and they're really not going to like me for this, which is why I've never been given like a fellowship of the Royal Pharmaceutical Society. First of all, the Royal College is is a new idea and is currently being defined, and I've sort of walked away from it all. It just became very political, with lots of different organizations fighting for who owned the pharmacy spot, trying to bring them together, getting excited if the word pharmacy or pharmacist appeared in a white or a green paper. And I just don't really think we ever had the voice, or ever, maybe we have now, but I don't listen to it. And I'm sorry, but I've just become quite disenfranchised with the sort of internal political fighting about who owns the pharmacy label. And I'm sorry to say that, but so I've not stood for office. I've not get involved. I've just worked much more from a point of view of putting the person and the patient before the pharmacy and the pharmacist. Yeah. And that's what I'll continue to do in my own small way, whether it's through Illuminate, whether it's through the consulting work we do primarily now with life science companies. I've reached out to a few pharmacy chains, but to be honest, pharmacy in this country, and I believe in yours, is really struggling to have any money to do sort of innovative work. And back to the bean counting, sadly, money talks, and we can talk about innovation and person-centered care, but ultimately you need to keep the lights and the wheels on, and that's often defaulting to the quantity, not the quality service.
So in the United States, Mark, you probably know this, but there are only a few states throughout the United States that view pharmacists as providers, and that they're going to be compensated and or paid by some of our government systems and some of our reimbursement structures, like Medicare. They call it Medicare Part D, for example. And so in the United States, it's only our physician that, from a universal perspective, at least from the national perspective, that they're considered a quote unquote provider of healthcare, and they're paid as such, as providers. And I think that the turf war is number one, it's stupid because it's not patient focused. But I think the recognition of pharmacists as providers, it's not about the politics of it, at least from my perspective. It's more about, let's get out of the way of the expert, so that the nerdy pharmacist that wants to get crazy into the pharmacological for specific disease states, they can really take the time to dial in to the study, into the follow-up, into the pharmacogenomics, into the, all of this data that's available to really dial in. So in the UK, are pharmacists viewed as the same level as your GPs?
Yeah, we're definitely providers. And again, we have really the sort of four areas. We have community pharmacy, or retail, as you call it in some cases. We have hospital pharmacy. We're really up there in terms of clinical pharmacy, implementing solutions, looking at prevention of side effects, reducing polypharmacy, all that sort of stuff. And really, I think, carry the clinical flag probably a little bit more than our community colleagues. And again, I'm not painting everybody. There's community colleagues who are amazing and really get the clinical stuff and intervene. Likewise, I'm sure, there's hospital colleagues who prefer to do the dispensing bit, et cetera, and the production side. But we also have academic pharmacies in the teaching bit, and we have industrial, people, pharmacy in the industrial side. And then there's lunatics like me that have done none of the four, played with two or three of the four, and then gone off and done something completely different. But yeah, we're very much providers. And back to that medicines experience, the thing I hear most, sadly, really sadly, because hospital pharmacy here, they're brilliant, they're fantastic, educated, erudite, often very communicative individuals. But what I often hear patients saying is, oh, I had to wait ages for my discharge medication. And I think to myself, guys, I don't know what the processes are in hospitals. I don't know, but do me a favor, just get that sorted. That is back to licking, picking, sticking. And forgive me if they need to do lots of checks and there's not sufficient capacity to do that. And I no longer understand the clinical processes and the governance and the safety issues involved. But it's horrible to be out socially and people say, oh yeah, pharmacy, it's the people that keep me waiting. It doesn't add to our professional image. That the supply side should be the basics. Just get it right and give us time and money and support to do the service type of stuff, because that's where we really add value. I mean, I think in California, and this may be right or wrong, but I think there's ATMs and maybe in other states where you can get your medicines dispensed. We're not quite at that stage over here, but if we don't add a function and a service, then I think ultimately we could be commoditized out of business.
Yeah, the will call bins that sometimes there's one called it's a kiosk called something like Pharmacy 24 or something like that, but you can embed this into the wall of your pharmacy building, and then a patient could come up, they might get a text or they might get a QR code, and then they could scan it onto this apparatus or their system. It would pull up the order. They put in their credit card, that it kind of verifies some things, that this is really this person, or face recognition, or I forget what the technology is. But that doesn't bother me of thinking there's pharmacists out there or pharmacy businesses out there that might say, oh, automation and artificial intelligence are going to take away the dispensing. And from my viewpoint, my opinion, watching pharmacy now for over 20 years, it's not really about the physical dispensing per se. Once the checks are done, once the safety is checked, it's really about the impact of that specific medication on the individual, especially the long-term. If it's just like there's patients out there who will take a medication, an antibiotic, for a very short period of time, and then that's it. They're not on medications. Well, great. They should be talking to their pharmacist about preventative things and start dialing into custom supplements or the way that you're living, or nitric oxide, or whatever it is. But if you are on a regimen, a medication regimen, it shouldn't just be a set it and forget it. It should be like, hey, let's check on this patient, I don't know, once a month in some cases, once a quarter in other cases, once a year, maybe in some other cases, but really dialing deep into maybe doing a saliva check or doing a blood check or doing something that gives more data and more access to that clinical pharmacist, which I think every pharmacist is a clinical pharmacist, where they're really getting super serious about the individual patient, so that we stop this fast food madness of just collecting the fee and getting the next prescription. And that's the reason that the United States is in such a mess, because we allowed our insurance organizations to dictate medicine instead of the physician and the pharmacist dictating medicine. We allowed our insurance people to take it hostage.
I think it's three levels for me, Todd. I think it's how can we, whether we're in community or hospital pharmacy, wherever it may be, or even in the industry, what am I doing as a pharmacist in order to help patients better self-manage their medicine and their surrounding conditions? So how can I empower them to do more and be less reliant on the system? Secondly, can we help them to self-care? Because even better if there's an opportunity not to have to get on medicines, which then segues very nicely into prevention. And if I wouldn't need to be on anti-diabetes medication if probably 30 years ago I'd had a little bit more support around my health psychology and emotional eating stuff. That doesn't make certain pharmaceutical companies happy, but it would make the providers happy, and it would make me happy. So I think we need to begin to, especially with obesity and all these things, we need to begin to think about, not a cure for every, what is it? A pill for every ill or a cure for every ail. I think we need to begin. Yes, we're paid that way, but how do we used to have healthy living pharmacies here, which maybe still exist, but as I said, I'm not so much into the policy now, but seem to have gone off the boil. And I do think there's something about, come on, guys, let's get out there and do more. And again, we need to think about how will that be funded. But I think there's some innovative programs out there, and really to think, as I said earlier, about let's think person, then patient, and then medicine in that order, not the other way around.
I love it, Mark. I want to just let our listeners know that Mark is active, not as active as I am. I think I'm on probably 3 to 4 hours a day, but you're on LinkedIn. You're on this LinkedIn system. It's a really good use of getting viewpoints out. It's also really wonderful for networking with other people that are thinking your way of kind of bringing that patient into the focal point and in the center of everything. But if you're looking at the screen, if you're following us on YouTube or something, you'll see Mark is available on LinkedIn. I'll put his LinkedIn link inside of our show notes, but you have to promise me, Mark, that you'll come back to TWIRx and we can dig into other things. Bring me something controversial. We love controversy. It makes for better listening.
Okay, I try to do my best. I think there's possibly something around how do we change the system to be focused on medicines taking, not just medicines dispensing.
Absolutely. You know? Absolutely. Hey, thank you so much, Mark, for being on TWIRx. We also want to say once again, congratulations for making a list that your votes came from people that believe in you and think that you're making a difference and see you as an influencer. And like in the Spider-Man movie, Peter Parker's uncle said, with great power comes great responsibility. And I think with great influence comes great responsibility. So putting you on the spot to be responsible and continue doing what you're doing.
I will try, and thank you for the ego boost, and I'll maybe not need so much comfort eating tonight. So thank you for that.
Yeah. Hey, we'll be right back with more TWIRx.
This episode is sponsored by Independent Pharmacy Cooperative, widely known as IPC. Established in 1983, IPC is the nation's largest group purchasing organization owned by independent pharmacy. With a mission of maximizing the success of community pharmacists, IPC works to provide members with access to effective programs and services designed to enhance profitability for independent pharmacy. Read more about our mission by checking out our website at ipcrx.com. That's ipcrx.com.
Hey, special friend of mine on TWIRx, fellow pharmacy industry maven, and now, unfortunately, Laura, I have to also put the term veteran, one of the veterans of pharmacy in a fellow Pittsburgher, Dr. Laura Mark. Welcome to TWIRx.
Thank you, and thank you for having me.
Yeah,
Very nice.
Just for some background, Dr. Laura Mark from Duquesne University, grew up in Butler County, just like me. And our mothers were like best friends through high school. And my mom or your mom or both of our moms were in each other's weddings or something like that. So it's just a small world, but that's another reason. I mean, there's a reason you're here, and that's great. But another reason on top of you being here is to be able to see there's some legacy here and how I've watched you and your career in pharmacy grow. And it's just cool. So welcome.
Thank you. Well, it's been nice to see us growing together too, as well, and all the great work you're doing and promoting pharmacy. So really appreciate that, Todd.
Absolutely. Absolutely. So you are the vice president of basically the entire pharmacy operations that has anything to do with Allegheny Health Network in Pittsburgh, Pennsylvania, one of our largest health systems in the entire area, and it's growing and it's growing. And the reason why I'm so excited to feature you today is AHN is opening a new pharmaceutical distribution center in Jackson Township, which is Zillionople, which is literally where I grew up, Seneca Valley School District. And I have friends and so many memories of Zilly to think that this technology and this opportunity is coming to that sector of Butler County. It's an exciting announcement.
It is very nice. So yes, we have a 20,000 square foot pharmacy that has opened, and we have multiple functions in this area at this location. So we have our central fill pharmacy and our central distribution center too as well. We house our central prior auth team and our refill team here, our MedSync program, med adherence and packaging, our call center for specialty and retail pharmacies, and then also our specialty team. So a lot of things that are happening here. We also have our central distribution team, which really supports our inpatient pharmacies and what we're trying to do around drug shortage mitigation, anything from a centralization, so 503B purchasing, RFID tagging. We also do some things that we're going to do for our ambulatory surgery centers and really exchanging some of their OR cards and tray exchange. So there's a lot of things happening here in Zelienople, and we're very excited about it.
There's just basically, we're all humans and things. We're so different. We just have different tastes and life things. So there's some of us like myself, and obviously you, that I wanted to stay relatively in the same area because I liked it. Even though our weather's crappy and our springs are getting too long and it's just gray outside. Although it's warm today, it's nice. But some people want to stay home, right? Some people want to grow up and just like, hey, I like home, I'm gonna stay here. That's the exciting part for me, to hear that someone is, at Butler School, high school, they love STEM, they'd like to go the technician route because they found out their friend was a pharmacy technician, or they want to go the pharmacist route because they've learned about the opportunity. Now there's an expansion of opportunity right in Butler County where it's involving what is happening in the future of pharmacy. And part of that is automation, technology, AI. To talk to us about what opportunities you think that's going to impact the next 5 to 20 years in Butler County.
So we're very excited about the automation that we have here and the technology, but there's still opportunities from it's really taking our pharmacists and our technicians and letting them work at the top of their license or the top of their practice too as well. And so that technology that we have in place really does help to support that. And the piece that we really like, so we're using some, even with our central prior auth team and our refill team, some AI in our Epic platform, in our EHR, and helping that. And then with this technology that you're showing right now, this really helps us, instead of technicians counting by 5, they can really be, or 10, whatever, they can be focusing on filling prescriptions for patients, getting them out the door. This has really helped us to support our hospitals. One of the things that we had, and the reason why we built this, is because we were at capacity at our retail sites, at our locations, at our hospital-based retail pharmacies. This has helped and allowed our pharmacists on site and our technicians to really focus on meds to beds program and discharge prescriptions, discharge counseling to patients, our med history program. So instead of focusing on the fulfillment, where our robotics could actually do that, as you illustrated, this really does help for our professionals to work at the top of their license and their practice. We're meeting and calling patients on a regular basis through a central fill, just coordinating all of their prescriptions, answering any questions that they might have, versus just that technical piece.
Laura, is this extending medication management post hospital stay and now assuring an adherence situation? Are you baton handing this off to a community kind of environment, or are you able to keep your patient tied in? And how does that work from an extension of care?
Well, that's what we're really excited about, is that by this capacity, even from our meds to beds program, sometimes it was a fill the prescription and go home. And then we didn't fill those prescriptions subsequent for those patients. But we'll be really able to keep those patients and be able to help them. We're really excited about our med adherence packaging and our med sync program, that if we identify patients that have trouble with medication adherence, we can enroll them in that program so they can have those prepackaged for them, and then they can get them on a regular basis. So I think we probably have about 4,000 patients already in our med sync program, and they're very excited about that because it's sort of automatic for them. Unless they have a question, they'll get those medications, and again, it makes it easier for them.
That's cool. Very good. Well, so I know that one part of your position in thinking is always like, okay, what's next to stay ahead of something, to stay ahead of the needs of community, or stay ahead of the needs of what the hospital system and the pressures that probably come down on pharmacy a lot of times. But is there anything that you're looking to the future to expand on that you kind of already proven? As a matter of fact, the facility in Butler County right now, it's up, it's running, it's doing what it's doing. What's that taught you about expansion and the ability to grow?
We're very excited about this facility here because if you show the space, it's very open. So there's no walls. And that was one of the lessons that we learned from other places who have similar facilities, is don't build walls, because everybody ends up taking down walls. So there's really the opportunity to expand from a fulfillment. This also supports, we have 2 pharmacist led clinics, where if our patients or providers need help from a more high touch for pharmacist, they can refer them into that clinic, and that clinic has a higher touch appointments with our pharmacist. And then we also fulfill those prescriptions too. And what we really like, again, about that is that it really helps that whole complete circle of transitions of care, coordinating that patient's medications throughout not just their acute stay, but also from an outpatient perspective too.
Well, I just want to say congratulations. I know how much work that you've put into this. This is a whole new chapter, but I mean, you brought together, this is the original story that I'd love for you to come back and tell us again, but to bring together, I forget how many, over a dozen, I think, so many different hospital systems that you helped to kind of merge together when AHN was doing what they were doing, and how costs and containment and expansion and continuing education and support and connection to EHR, and like, oh my gosh, Laura, like, bravo to what you've put together over the years. And like I said, I've been documenting it based on podcasting.
Well, we have a great team, and so I'm very fortunate to work among a great team of pharmacists, technicians, leaders, and then really also a support team from our leaders. So really appreciate that.
Absolutely. All right. Well, we have to have you back. Maybe come down to the studio sometime and bring your crew back, and it'll be fun. But thank you so much for being on TWIRx today, Laura.
All right. Thank you again. All right. Nice seeing you.
Hey there. Welcome back to TWIRx. I have a special guest from the great state of Pennsylvania, my state of Pennsylvania, Eric Pusey. Eric, I haven't talked to you in some time. It's so good to see you.
Same here. Really appreciate you giving me a call.
Absolutely. So big news came out this week in pharmacy. I'm reading from the spotlightpennsylvania.org. Once again, that's spotlightpa.org. And the headline says, drug plan middleman face new oversight push as Pennsylvania pharmacies close. And this article kind of digs into some of the things that are happening within Pennsylvania and the PBM reform bill that is also mentioned. And you were quoted in this article. So I wanted to reach out to you and get an update from you. What's happening in the state of Pennsylvania right now in regards to PBM reform?
Well, we were very active in getting something that's called Act 77 in the state of Pennsylvania, finally put into place essentially a year and a half ago. And many of the reforms actually did not become active until January 1st of this year in 2026. However, the way the law was written, it was being taken care of, or the enforcement of it was left to the insurance department. And the insurance department, first of all, determined that they did not have jurisdiction for approximately 70 to 80% of the insurance plans that were not physically located in the state of Pennsylvania. Well, that only left about 20 to 25% of the plans that they had any enforcement capability of. And by enforcement, that was very limited in what they can do as well. So they are in the process of trying to do some of the studies. They're doing some long-term studies on pricing. They're doing on many transparency issues that they're following up on. However, we need to have some teeth to that law. And the only way that we can basically get that is by having the Attorney General of the state have that enforcement capability and have the ability to enforce what is on the books, and to add some other stipulations that will make it a little bit more difficult. One of the major, there's a couple different components of the new version or the updated version. The primary part is to really get that enforcement capability, having somebody that can actually not only just make a suggestion, but actually do something about it.
So we also heard last week that the state of Tennessee is pushing that PBM should not be able to own pharmacies. It doesn't make any sense. You can't be the insurance provider and then choose your own pharmacies and then lock everybody else out based on reimbursement, based on pricing opportunities, based on steering patients to specific pharmacies. It's stark law. I don't understand why we've even gotten to this point. How can you allow an insurance company to be there's no checks and balances. There's no auditing when you have that model. So do you think Act 77, do you think that this goes far enough?
It doesn't at this point. And again, one of the goals of this new legislation, if we were able to get it up and running, is that it will add to the prohibition of having the large PBMs, and that would be primarily CVS, not having the ability to own their stores in the same jurisdiction as the PBM. Other states have already initiated this. Arkansas would be one. Tennessee is the other. There's probably three, or actually there's more states than that have actually either already enacted this stipulation. It's in the courts. It was immediately appealed. The litigation is going on. It will probably take some time, obviously, before this finally gets adjudicated, whether it will actually come into fruition. But other states have already approved it. So the legislation is there. So the purpose of this is to get Pennsylvania on board, get it on the books. They'll challenge it. Of course they will. But the important thing is that it's there. Because again, having the same PBM, as you mentioned, directing a lot of their business to their own stores, that it's not only a conflict of interest, but in my personal opinion, it is antitrust as well. That's another whole issue that, of course, has been adjudicated for the last 20 years. And again, the PBMs have always won on that particular issue. But that is an issue that it keeps on coming up, and that's one of the reasons why they're looking at PBM, looking at the models that they are, and do they now have that monopoly and will they be able to go ahead and perhaps split it up in some way? Again, these are all things that are on the horizon, but again, they need to happen, and they need to happen fast.
The access to pharmacy care throughout any state, not just Pennsylvania, would be completely opened up, where you would say hey, listen, it's okay to be an insurance provider. If you want to be a PBM, do your PBM stuff. I think that there's auditing to be done and PBM reform that splits hairs and starts to get into the details. However, when it comes to operating pharmacies and being the same owner, you're the insurer, you're the PBM, the pharmacy benefit manager, you own pharmacies, that limits your patient base to getting access. And when you have, let's say, 25 pharmacies from downtown Pittsburgh, let's pretend, and you start drawing a circle outward, and you get 2 miles out, and you get 5 miles out, you get 10 miles out. I don't know how many pharmacies you would say was in that circle, but it's definitely less when you start going out into rural areas of the great state of Pennsylvania, into the Poconos or into parts of Lancaster County or something, where the only pharmacy for miles and miles is an independently owned pharmacy that's set up, that has clients, that has patients, that have an insurance that they can't even use properly, or it gets rejected, or it's pushed to mail order, and they're not getting the hands-on services that make quite a difference, especially in disease states that are chronic. So the ending of this article, it says that the proposal will try to address where the court cases involving PBMs taking place, with the lawmakers saying that residents should not be forced to travel across the country to defend their access to essential medical care, and that their legislation would require PBMs to appear in the Pennsylvania courts for any cause of action arising from conduct within Pennsylvania, and that PBMs would be prohibited from directly owning a pharmacy license in the state. And then it goes on to say, critics of that type of relationship say it gives an unfair advantage to PBM affiliate pharmacies. I don't understand the wording. Whoever wrote this article, they obviously don't understand it. They use the word critics of this type of relationship. They don't understand it shouldn't be a critic, it's a fact. So when you have an insurance company that owns the actual pharmacies and they start building stipulations of what you can do either inside that network, what drugs you're getting, what flexibility is given to the physician, what flexibility is given to the treating pharmacist that's tracking the patient's care and treatment. So a shout out to this, to this author of this article with this. Matter of fact, I'd like to reach out to them, Mr. Ed Mahan. Ed A. Mahan. I mean, longtime writer, awesome writer, but I just want to flag his writing and saying, listen, this is there shouldn't be two sides of this. It's critics means there's two sides. Hey, Eric, you're being a critic of this, or hey, Todd, you're being a critic of this. And I'm like, dude, like, you guys don't understand. That isn't in anyone's best interest. No matter, the only best interest it's in is that stockholder of CVS Health, and CVS Health PBM. It's not even in best efforts of getting pharmacy care out. For example, Rock On Walgreens, they're not owned by a PBM. So, try to survive or try to thrive in whatever area you are. Your business is being crushed by this PBM/pharmacy ownership model.
No, it's a situation that obviously pharmacy deserts are a fact. They are reality. They do exist not only in Pennsylvania, of course, but throughout the country. And again, these laws are designed to give our patients more flexibility in getting the services that they need. We know that independent community pharmacy and some smaller chains, they're able to provide services that the big chains that are left, when there's only a few of them, they cannot provide because of the volume of scripts that they're doing. They don't provide the services that we are able to provide our patients. And that really is the bottom line, is that our patients deserve better. It's not based on just price. It's the convenience. It's the service. It's all of the auxiliary functions that our community pharmacies can provide to our patients. And that's really the bottom line. And that's what this whole thing is about. Trying to keep our doors open, trying to keep our pharmacies running so we can provide better, good human services.
Yep. And having a model, Eric, that's in place that encourages the new owners to have reason to open new pharmacies in places that we've seen a collapse in pharmacy care. And that's throughout the entire country.
No question about it.
Build a reimbursement model that puts everyone on a level playing field and gives an entrepreneur an opportunity to build a pharmacy care business in a community that you have to drive 5 miles, 10 miles, 20 miles away, or it's not on a bus line in order to back up more public health services. And that should be tied into reimbursement. That should be tied into state Medicaids. That should be tied into encouraging that we do more pharmacy services. And we see that the macroeconomics of the current PBM model has crushed pharmacy care throughout the nation.
There's no question. And those services, we need to be reimbursed for those services.
True.
And again, the state of Pennsylvania, it has enacted some of those payment models on the Medicare, on the Medicaid side and on the managed MCO side, on the managed care side. And there is some availability of extra revenue coming in, but it's a long, hard process to try to get that not only set up, but implemented into our pharmacies. But that is a separate issue. The reimbursement models, when we go back to the original Act 77, when I mentioned that the Insurance Commission is working on studies, that is the main study that they're working on. It is now, I was able to get all this information from a FOIA request from the department, from the insurance department. And the study is ongoing. There is action going on. They've had committee hearings, but the study's not going to be done until at the earliest, the summer of 2026. So this is a 9-month study that's looking at whether it be NADAC plus cost, plus a fee, or whatever model. It has to be different. The model has to be changed. We can no longer continue to be paid on AWP and be AWP minus, which is a fictitious number to start. It's crushing the independent community pharmacies. It's crushing every pharmacy.
Absolutely. Eric Pusey with Better Health Pharmacy and Wellness out of, is it Oliphant?
Oliphant. Like the actor, Oliphant.
Oliphant. Eric, this has been great to have you on TWIRx. Hope to have you back soon. Thank you so much.
You bet. Anytime.